Tim Bates. I'm one of the GPs here at Fort House Surgery in Walton-on-Thames. I've been a doctor just short of 30 years and a doctor at Fort House for just short of 20 years. And I'm delighted to be joined by Jackie.
Hi, Tim. My name's Jackie Davey. I'm a member of the patient participation group, which I joined hoping to make a contribution to the practice as a thank you for the amazing service my family and I have received over the past 16 years. And I have been asked to put some general questions to you, which hopefully will be of interest.
So we're going to do a quick 20-minute presentation on the pressures that we're facing at the surgery, some of the difficulties we've had around access to appointments and some of the improvements, and then Jackie's going to come in and give me a quick grilling. Is that okay?
Thank you, Tim.
Thank you so much. Right, I will share my screen and I hope then that everyone can see this. I'm sure I'll get a tap on the shoulder if I can't. Our motto here really is traditional general practice in the 21st century, and what we're trying to achieve are some of the traditional values around general practice as we move into this digital universe. So we gathered some feedback through the PPG, and I'm immensely grateful to Jackie and the team for talking to you as you came through our flu clinics about your experiences of services. And though I'm delighted to say largely positive, there are some key messages. And this is what we've been hearing really in the last 3 weeks and the last 3 years, that perhaps we're a little too centric towards the needs of the practice and our patients, that the service has perhaps deteriorated. We've got too many patients. Mixed experiences with still high standards, long queues for the telephone, aversion to the website. The moves made us far less personal than we once were. Doubt and lack of clarity around processes. We're the best surgery in the country. Fabulous practice, always responsive, but the telephone window of 4 hours is too long. Miss not being able to phone and having to wait a week to see anybody. And a request to clone Dr. Bates. Harriet. Anyway, flattering all the same. Thank you very much. And that's complicated further by some of the my colleagues regard as toxicity of the headlines that started after the first wave in the pandemic and the narrative within the media and within politics. It's made life very difficult. So how does that tally with your experience? So this is a graph showing satisfaction of access to appointments throughout the whole of Surrey, and you'll see that there's been a gradual drift down and then post-COVID a significant drop in satisfaction rates. Surrey Heartland started around 76% satisfaction in 2017, and now we're down to 2023, 59%. You'll be pleased to know that Fort House Surgery is still sitting around 87% on the access. And here we are as the red line amongst all the grey of all the practices, and from 2017 to 21, happy days, right towards the top of the bunch. But you can see that on the National Patient Survey, our satisfaction with access has dropped. The 2022 data is captured from the end of 21 and beginning of 2022. So it was taken before we moved. So the satisfaction with access was dropping before we moved. But our team are working incredibly hard, but it's very difficult. They're telling us that it's never been so bad, that we're too busy, there are a few breaks, they're exhausted, they're frustrated. We've had staff in tears, particularly where there's some conflict points around not being able to offer the appointments that people would like. Overworked, undervalued, and this sort of digital age bringing very immediacy of problems and solutions and demand. And it really leaves us scratching our heads a little bit, thinking, well, what can we do to understand the problem and improve? So here are the numbers. These are graphs that I've been keeping since we went digital. You'll see from the end of wave 1 that we were receiving around 4,000 calls a month. December 2020, 4,000 calls a month. December 2022, over 6,000 calls a month. Now, this is a very busy slide, but the yellow arrow is what I wanted to show you. And these are the number of days that we were running out of appointments here. So from April to May 2022, we were running out of appointments at the surgery half to 3/4 of the time. But from November, we haven't run out of appointments at all. And I'll show you what's changed in a minute. A further review of our appointment book, when we looked at 2013, we were seeing on average patients 3.59 times per year. And that's now moved up to 5.28 times per year. And if we look at the total cost to the NHS and divide it just into the telephone and face-to-face appointments, that's about £28 a contact. And that obviously covers our expenses here, heating, lighting, our reception team, our secretarial team, our nursing team, £28 per contact. So why is our demand escalating and outstripping our capacity? Well, there's several reasons. Firstly, we are experiencing more illness within our society. Of the 5 million economically inactive adults nationally, about 40% are permanently incapacitated and will not return to work. 30% are on waiting lists, and of our patients 75 years and older have on average 4 or more major medical conditions. So the work is more complex. You'll be familiar with this graph of waiting times drifting up through austerity and terrible since COVID. And I really just wanted to use this slide to illustrate that whilst people are waiting for care, they rely on their community services. So we're looking after the hips and the knees and the pains and the heart failures. We can't access care in hospitals as much as our patients can't, and that adds to our overall burden. This graph is the A&E performance targets, which you can see the 4-hour target in red has been drifting and then accelerating with COVID. But more worryingly, the blue bars are the patients who are waiting more than 12 hours from the decision to admit to get into a hospital bed. Now, for each 80 patients on this list, there will be one extra death. And in February 22, there were just short of 23,000 people waiting in excess of 12 hours. Our social care funding and our ageing population is represented here, but as you see, the problem escalates, the funding in social care has not. And going forward, we anticipate a doubling of our number of 85-year-olds by 2045. This slide came out in COVID, just a quick illustration as to what COVID has done or what it's doing to our society and our health service. Wave 1, obviously, COVID killed at a frightening rate a lot of our very vulnerable patients. In fact, a rate that I believe is higher than the average for the Second World War. The next impact was on functioning of key healthcare resources, treatment of stroke, treatment of heart attack, ambulance waiting times that should have been less than 18 minutes went up to an hour. The third wave, which is playing through now, is the impact of chronic care and the care for patients with chronic conditions, and wave 4, the psychological and social and economic factors that are playing through, not just with COVID, but obviously the cost of living crisis and the various reasons for that. So I just wanted to tackle the money here. I will say at the outset that I do not think that we just need more money. There is a strong case for reform, but reform needs investment. If we'd stayed on the same trajectory through the austerity years, we would be about £50 billion a year further ahead. And this is really what we've got for our investment. We've got the lowest per capita spending amongst comparable countries. We've got the lowest number of beds per 1,000 people. We've got the lowest number of MRI scanners, lowest number of CT scanners. The tools to do the job are not being supplied and making it more challenging. And just before we get into the idea that Dr. Bates is shoveling it all into his big deep pockets, you'll see from this graph, the red line, that there's been a 7% improvement in pay for GP partners from 2005 to 2020. And it's not going to our social care or nursing or hospital colleagues either. And then the question is, well, how does this play through into our workforce? Well, you can see that actually the workforce in hospital has grown strongly as the population age has grown, but the total number of GPs has significantly dropped. And this chart, I know it's a bit busy, I'm sorry, but the dark blue is the number of GP partners. Now, GP partners like myself don't just see you as patients, but we run the business. We are employers. We're financially responsible. We handle complaints. We need to be here running the businesses, and our numbers are dropping significantly. The number of employed doctors has gone up, but not enough to counteract the overall drift. And you'll see there's a rise in trainees, but trainees obviously take time to develop their skills and develop their what they bring to a practice. But also in my last appraisal, my appraiser, who is a trainer, told me that of his 10 trainees that had come through the doors recently, 8 had gone overseas and 2 are locums. This graph represents the inequalities when it comes to access to general practice. So the blue line in very affluent areas is way above the red line in poor areas, and just highlights that actually access to general practice services is worse in the most deprived areas. But despite this story, the number of GP appointments delivered per day has risen from just over 1.2 million to just short of 1.4 million over the 3 years during COVID, whereas the elective treatment pathways for hospitals are entirely flat. And this is data from The Economist showing that GP appointments have increased, but yet the national mood around access and satisfaction with appointments has deteriorated. So how have we managed to provide more appointments? through 3 schemes: digital transformation, which you'll be familiar with. We've expanded our team using allied healthcare professionals, and we've explored new ways of working: networks, federations, neighbourhood teams, and the community pharmacy scheme. Now, this chart here, we posted in our surgery in 2019. So we started this digital transformation journey before COVID. We asked you if we could maintain access and good continuity. Would you have preferred to have not come into the surgery to have your problem solved? I was aiming, hopefully, to maybe move 15% of our appointments off the appointment book, and a staggering 63% of respondents said that they would have preferred remote consulting. So we've made 3 system changes. We looked at multiple different systems on the market, and I'm afraid that there will be more innovation and iteration to come as we respond to the escalating pressures. But the key themes here: we want to maintain access, we want to maintain continuity of care, we want to answer questions before they arise, help people self-manage their care, move people to the right place, obviously use our expanding workforce, and free our GPs, who are shorter in number, to be repurposed to the most complex and the most challenging of clinical cases. Here's the change we made in November 22. You won't have noticed, it was all behind the website, but by moving a doctor and an administrator into the same room and redesigning our appointment book, we enabled a theory of trying to get the right person to the right place as quickly as possible and get it right first time. From April to November, we were running out of appointments 50 to 75% of the time. Since November, not once. And our capacity has increased from 1,200 calls a week to over 1,500 calls a week, with fewer complaints and fewer staff in tears. And I have to apologise for the shabby quality of the slides, but that's my finger drawing on an iPhone, and I can't make it better than that. I'm sorry. Every digital policy needs an inclusion policy. We recognise that 7.8% of adults nationally don't use the internet. That's roughly 200,000 people in Surrey. Elmbridge, though, is the second most digitally included borough in Surrey. So we are quite literate as far as using our digital technology goes. Our inclusion policy is: please call us if you can't use the form on the website. We will do the form here because it channels everything through the same point, so we can measure our work and I can generate pretty graphs. But this will not get you further ahead in the queue. So let's meet the team. Marina is our clinical pharmacist. She comes to us with 18 years of experience. She's an independent practitioner. She manages type 2 diabetes, high blood pressure, complex medication reviews, searches, audits, queries. She does all our clinical safety work, and she's a champion for antibiotic stewardship, because we do still have to look after how we use antibiotics and reduce multi-drug resistance. John, our paramedic, 24 years in the business. He's taken a great interest since he joined us in child and adolescent mental health. He's helped us develop our Veterans Charter and Veterans Services, and we're also developing our Autism and Learning Disability Charter, and we're aiming to become an accredited learning disability and autism friendly surgery. He's also a fantastic trainer in the emergency basic life support and advanced life support for us as well. Charlotte, our advanced nurse practitioner, 23 years in the business, started out in paediatrics and intensive care and A&E, so she's fantastic at looking after your young ones. She's got master's levels qualifications. She's our diabetes lead, and she was lead for diabetes in Surrey for 3 years as well. The new ways of working have really been about working with other practices locally and then throughout the wider area, and bringing new services. And you will already have experienced these services, but you may not have been aware as to why. So the primary care network that we're part of includes Hersham, Weybridge practices and us. We've been able to share resources and efficiencies. We've brought in our pharmacists. We've got a new physiotherapy service starting on the 19th of October here, where we'll be able to offer 22 appointments in the surgery. Extra blood testing, our social prescribing service. So we've really got professional colleagues on the team now who can help us to get to grips with some of the socioeconomic drivers of ill health. The federations are 42 practices wide, so from Woking up to Staines and across to us. And if you've ever been asked to go over to Walton Health Centre or over to Chertsey for an urgent medical appointment, it's the Federation that are providing it. We've got extra phlebotomy appointments, we've got extra spirometry, an improved service to the limited one we had before, and they run our paramedic home visiting service for us as well. They've been doing your COVID flu vaccinations, that's why you had to go off to Chertsey Halls, and also our housebound flu and housebound COVID vaccinations as well. And all of these services have come out through working as a wider group of practices at scale. One of our new services is the community pharmacy service. Some of you already may have contacted us with relatively minor medical complaints seeking assistance, and we will divert you to a local pharmacist where you can be spoken to on the phone or seen face to face. And generally speaking, simple things: bites, stings, rashes, coughs, colds, sore throats. Emergency contraception, a couple of our practices locally can actually prescribe this for free on the NHS now, management of infections, and the government are looking to extend this scheme to something called Pharmacy First, where pharmacists will be able to prescribe. And here, if we can take out a lot of the relatively simple, non-complex work, it frees up your GP's appointment book, so we can add capacity, improve access, and we can begin to bring along a model that's based more around continuity of care and chronicity. The integrated neighbourhood teams is looking forward a little bit. We've just had a reorganisation of the health service in the last 18 months, so 15 months, apologies. And so now North West Surrey Alliance are running our place, and I'm grateful to them and their support for hosting this webinar and question session today. And we're looking at how practices can collaborate with community teams and community services, designing systems to try and bring patient care closer to home with an integrated multidisciplinary approach. That basically means that we're going to work closer with our pharmacists, district nurses, rehab teams, and so on. And this aligns to a review of GP services that was published a little under 2 years ago, looking at how we could work together to provide urgent care and then work together to provide planned chronic disease management, and trying to improve capacity and access to general practice, and that's known as the fuller stocktake. It's still under development, and you will see further iterations and further services coming our way as a result. Now, the move. We picked up some concern that the move had adversely affected our performance here, and you can see that actually our access to services was struggling before the move. But we actually have fewer patients than we had in May 2016, where we were experiencing some really positive feedback. We've added services. We've got the abdominal aortic screening service. We've got ear microsuction. We've got nurse-led women's health clinics. We've got a new in-house mental health service, which filled a very clear gap between the secondary care services for mental health and us GPs looking after you. No stairs. That's such a relief. Not fit for purpose. You won't hear me clattering up and down the stairs at Fort House Surgery anymore. And we've improved our accessibility, not just the surgery being on a single level, but actually we've moved closer to the centre of population, so more people can walk to our surgery than ever before. We've increased the number of clinical rooms. We've got an operating theatre where we do minor surgery, coil fittings, implant fittings, and we've also been able to fit our surgery pods so you can take your own blood pressures, make prescription requests, and enter simple data that will help us look after you. The future. Well, obviously, this topic of conversation is around improving our access and trying to rebuild our capacity. And how can we do that? We're looking at new models of improving continuity of care. We do know that 6% of our population consume 26% of our appointments. That says that we're not offering the right model, and we are going through some work and some support through the ICB, which is the health authority, to help us look at how we can improve the continuity and perhaps reduce some of the on-the-day demand. We want to increase the use of the NHS app. In fact, from the 1st of November, everyone will be able to use their NHS app to access some records, letters, to look at blood tests, to book appointments. It will mean perhaps interfacing with the website less, and it should be a little bit easier. I think in Surrey, 90% of people move to the NHS app, and I think the national figure is around 60%. So a lot of us are literate and happy on using the NHS app. We want to enable you to better self-manage your care and your health, and improve the website and the accessibility and ease of use. A quick word on the website. The 2 iterations before were kindly delivered through the health authority, but there's a difference from us managing our own issues here to a health authority running 104 different practices. So we are actually, I think from today, hopefully going to switch over to our new website where we'll be able to control the content and make improvements as we pick them up far more simplistically. The digital triage model is here to stay, and if we can develop it further, it may then allow GPs to redesign the appointment book and perhaps move to 15-minute appointments where we'll be able to really get our teeth into some of the complexity. We want to work with you to improve your experience of healthcare here at the surgery. And that's why our work with the PPG is really important and why feedback is really important. So if you've got feedback on this webinar, please email us at forthousesurgery@nhs.net. Would you like a quarterly webinar? I'm very happy to host a regular series of meetings. I'm very happy to do them in person. We're doing a recorded one to begin with as a test, but if this has got legs, I'm very happy to go live. What would you like us to talk about? What would you like us to address? Would you like speakers? Should we be talking about weight management services, diabetes management services, mental health services? Would you like to contribute to the conversation? Could you join our PPG in person or virtually? And these are questions that I'll leave out there, and we'll look forward to receiving your feedback. But I think I'm around about 20 minutes, so we'll invite Jackie back in and we're going to do a little bit of a grilling. Okay.
Thank you, Dr. Bates. I have questions from patients who attended for a flu vaccination and were interviewed afterwards by members of PPG. The first question was, if I have requested to see a doctor, why am I given an appointment with a nurse or pharmacist instead?
Well, I hope we've addressed some of these questions for you. The background here is that recruitment and retention less so here. People are happy here largely, but recruitment's been difficult, and there are some amazing skill sets out there in the workforce. And the addition of John, Marina, Charlotte has really freshened our team up. They bring extra insight, they bring extra skills, and we've been able to develop services around them. In addition to our HPs, we've been able to develop our team of nurses who've got interests in providing services around menopause and women's health as well. So what we're going to try and do here is use our team to the best level of our ability so we can meet the request that people are making and try and get you the right offer of a service first time. Is that okay, Jackie?
Yep, that's fine. Why does the receptionist need to know why I want to see a doctor? Who else sees my information in the surgery?
So that's a really good question. And there's lots in the national news around data protection and work with external providers, and I'll leave that with the politicians, but I can understand the sensitivities. Quite simply, we want to look after you to the best of our ability with the limited resources that we have. To do that, it really helps us to have as much information up front as we can. So if I receive a digital triage that says, prefer not to say, I've literally no idea whether someone's got central crushing chest pain or whether they want to talk about an ingrowing toenail. So we will ask for more information. I want everyone on this call, and in fact all of our patients, to be reassured that we take confidentiality very, very seriously here. Obviously, it's a key ethical construct of our practice as general practitioners, and we're bound by the GMC's Good Medical Conduct Guides, which obviously heavily emphasises confidentiality. But every single member of our team also has a confidentiality statement worked into their contract, so it would be a breach of contract as a breach. Also, all of our team undergo regular training on data protection and confidentiality as well. Without you feeling that we handle your data confidentially and sensitively, we can't run the conversation that we need to help you. So I would encourage people to trust my reception team and to trust, obviously, all the medical team here, and try and exchange as much information up front as you can, because it will help us help you and get you to the right place as quickly as we can.
Next question, Dr. Bates. Why can't I always see the same doctor? I don't want to have to tell my story every time I have an appointment.
Fantastic question. The principles here of access and continuity, and we have to balance the two. We don't want people waiting to see their favourite doctor, again, if they've got central crushing chest pain or they've got a sudden onset stroke. So we will always try and provide continuity of care where we can, but access has to be the important or the overarching principle, because essentially to us as doctors and nurses and all of our team, the patient in the waiting room is equally as important as the patient in front of you. And so that is not a simple platitude, that's a reality of the way that we work. So if we're looking at our lists or looking outside, please don't take offence. We have to be able to look after everyone in the right time frame. And if we have to sacrifice continuity to give you access for your own safety, then that has to be the overarching principle.
Next question was, why does the website close at 4 p.m. and at the weekends? Why can't we submit a query whenever we want to?
So we're open from 8 till 6:30 every day, and we close the website at 4 o'clock so that we can collate all the calls for the day and allocate work. But we are still open after 4 o'clock. So if there is any urgent medical condition that needs advice, and I'm pretty sure the website will say it, and if it doesn't, I'll make sure it does, we expect you to call. So the chest pains, the febrile babies, if there is a need, we still expect to receive the calls from 4 o'clock.
Next one. Why am I not automatically contacted with my blood results when they come back to the surgery?
Well, that's a tricky one. That's just about volume. I would say that 95% of the blood tests that I'm looking at are completely normal. And so it's only a small number of blood tests that need a further conversation. The reality is that we don't have the resources to contact everybody to tell you that your blood tests are okay. We do, at the point your blood is taken, hopefully remind you to call in or to use our website to access, or at least to find out about your data. And of course, from the 1st of November, the NHS app is going to allow you direct access to those blood tests as well.
Next one is, I'm waiting for an appointment at the hospital, but it's taking months. How can my GP get me seen quicker?
Well, that's a bit of a tricky one because as I said in the talk, we struggle with access to care as much as anybody else. And we don't have any levers to pull in the hospitals. If we are monitoring you on a waiting list and it's very clear that your medical condition has changed and deteriorated, we will obviously escalate your case as an urgent. And in fact, I've already been doing that for someone this morning. But we don't have any power over waiting lists or any influence. And sadly, some of our waiting lists are quite significant. Neurology, dermatology, vascular surgery pushing a year, ENT 8 months. So we're trying to provide as much care for people whilst they're waiting as we can. If you feel that your clinical case needs escalating or there's just simply an information vacuum and you don't know what's going on, we ask everyone to call the hospital. Now, I know that phones often ring out or people are not getting through. So if you are struggling to access your hospital, there is the Patient Advisory Liaison Service known as PALS, and we'd recommend that everybody call who's struggling to access their secondary care, call PALS if they can't get hold of their individual teams. Is that okay, Jackie?
Perfect, thank you. A 4-hour window is too long to wait for a call back. Can this be shortened to say 2 p.m. till 4 p.m. and 4 p.m. till 6 p.m.
Yeah, I think we do need to do something along those lines. I do feel a little bit guilty that I'm working for British Gas that will call you sometime between 2023 and 2025. We need to, but we are trying to develop and improve these models at pace against a very difficult background. It's a very common source of feedback, and we will look at this. And I think once we've got our digital model right, and we're pretty much there, there's still some further iterations to go. I think that's going to give us a chance to manage our appointment book a lot better. So perhaps we can give a narrower window so people will be more aware as to when a call might come in, but it's one for the future for us.
Great. Dr. Bates, I know you're keen for more personal questions about Fort House surgery staff. I believe that one staff member works at Pentonville Prison.
Yes.
Can you tell us a little bit more about this?
Yeah, so we've been lucky. We've been joined by some excellent salaried GP colleagues, and you're referring to Dr. Allfrey.
I am.
Who works with us on Monday and Wednesday, and on Tuesdays she works in Pentonville Prison. So she's got really good skill set around health inequalities, around mental health and neurodiversity, and in particular medications of addiction as well. So she's been doing some really good work with Marina, our clinical pharmacist, looking at some of the drugs of dependence that find their way onto people's prescriptions. And it's great that we've been able to utilise her resources. We've also got a colleague who works in a hotel looking after refugees in Feltham, which is a world away, quite literally. Well, maybe not literally, metaphorically, isn't it, Jackie? Sorry.
This is true.
From the work that we do here. And we are just delighted to welcome all members of our new team and lean into some of the skills that they bring us.
Next would be question, what hobbies do the staff enjoy? We do know that Dr. Redfern plays golf and that Dr. Ratcliffe has climbed mountains. Can you add to this?
Yeah, I much as my children really rip into me and take the mick out of me for this. I'm a volunteer ranger in Richmond Park. If I could, I would build Fort House surgery without a roof, so we could at least connect into the natural environment every single day. I've got Dr. Jones is well known, I think, with her Girl Guides and Brownies locally. She'll shoot me if I've got that wrong, but heavily involved in dance. We've got lots of interesting characters and interesting interests outside of the surgery.
You certainly have. Changing the subject slightly, you've mentioned your own health issues over the past year or so. Are you over these now, Dr. Bates?
Not quite. It's probably been the worst year in practice that I've ever known, just from the pressures, but it catches up with you. So no, I've had a few. Well, as you know, I was running a flu clinic when I was sitting in atrial fibrillation the other day when we were together. So you might not have known, so I covered that up well. But no, I've got
that quietly.
Yeah, I did that quietly. No, it's been very difficult, and stress, I think, plays its part. No, I've got to have a little heart procedure and get things done. But we know we have an issue with our service. We know the problems. Some are in our gift and some are outside of our gift. We will work tirelessly to improve what we can within our gift and hope that the environment in which we operate improves over the next few years, and none of us know which way it will be going. Within that, I have to keep myself healthy and I have to keep my team healthy, which I think is why it's really important for us to share some of the challenges we have and hopefully share some of the human stories that are behind the scenes here, because it's been difficult, but it will not stop us trying to improve the package and the service that you get here.
Excellent service. Your amazing practice manager, Harriet, she's a highly qualified radiographer. Where did she work before joining Fort House Surgery, and how did you persuade her to be part of the team?
I still ask myself that to this day. I've literally no idea. We were lucky. We had a practice manager, Debbie Woods, with us she recruited me. So Debbie was with us a long time. And we went out to advert, and Harriet was one of the few who applied. If you look at Harriet's skill set, she was a radiographer. She developed her career in Chelsea and Westminster. She ran a 300 staff diagnostic imaging unit in Chelsea and Westminster. She was part of the London Olympic Games healthcare planning, and then came to us with this CV, and came to us at a time where we were desperately trying to move. There were lots of complexities around engaging with the community, trying to maintain services. We only had 6 clinical rooms, Jackie, when I started, for 13,000 patients. To put it into context, if you were going to build me a new surgery for 13,000 people, it would probably need to be 6 times the size of Fort House Surgery.
Yes. Yes.
So we were operating out of a building that should only really have housed about 4,000. So there were lots of complexities, and for Harriet to bring in her experience of managing a large unit, diagnostic unit, get us the move. These are the kind of people that we totally rely on here for our administrative team. We cannot do this job without. We could not have been in this building without Harriet, but Harriet's wider team who got us in here as well. Exactly. So I have to give a special mention to my deputy practice manager, Julia Vi, who really weathered all of the logistics about schlepping us from the old site into our new site here.
Lovely.
How we got her, I've no idea.
No, but she's here. That's
she's here.
The most important thing. Do you still practice acupuncture?
No, that went in the pandemic.
Oh, that's a shame.
So the acupuncture went because the face-to-face went, but actually I was lucky. I then took up a position with the old CCG, and I'm clinical director for mental health and learning disability and autism. And that position stayed now through the new ICB, as it's known. So I work on a Friday as a deputy to the chief medical officers and clinical lead for mental health, learning disability and autism. And so that gives me a 3.5 day week at the surgery, 3 days and then an admin session, and then a day a week at the ICB, either remotely or the offices in Woking.
Right. Dr. Bates, where do you see the NHS in 5 years' time? Do you think it will be a service that has to be topped up by a financial contribution, from the population?
I think this is really challenging, and I think that the bits of the NHS that we love working in it is the free at the point of access, and as soon as there is any sort of levy or charge, there's an automatic gatekeeping role, and there is a profound concern that by charging people to access services, that they won't take those services up. I hope it's not overstepping the mark to say that the difficulty in accessing dentistry services is perhaps one example where it's not immediately and equitably available across the country, and that people are then making budgetary decisions about their healthcare because they can't afford to see a dentist. No. And we're seeing lots of this play through in ill health, because good dental care and good nutrition, good oral hygiene, as well as good nutrition, is key for well-being. Even heart attacks can be traced back to inequalities around poor dental care.
That's an interesting one.
So I think we would be distressed as a group here to see people being charged at the point of access for fear as to who might be denied care. But there are some hard decisions coming up. You can already see the hard decisions being made around what is covered in the NHS, what is not. But I think if we can keep them central and actually maintain free and equitable access at the point of contact, hopefully we'll survive.
Hopefully, yes. In your opinion, bearing in mind the ageing population, do you feel that over 75s are discriminated against if they need a hospital procedure?
I haven't seen active discrimination, but there's all forms of passive discrimination against all forms of group right the way through. So there are hard commissioning decisions being taken. And I think that those decisions are going to affect lots of different age groups. Our over 75s are the highest users of healthcare, and they have the highest demand. So I probably wouldn't consider it discrimination, but could the way in which our service is changing offer a better service to people who have more complex health needs and complex care requirements? I think the answer is yes. I think the marriage between the social care teams and the healthcare teams in the forms of ICBs and ICPs and so on has been long overdue. And to actually have a shared responsibility towards our elderly population now between our social care teams and our councils and our healthcare teams is a real breath of fresh air. Jackie, I'm an old cynic. I mean, I've seen 15 health secretaries in 30 years. I mean, you can't run a functional business if you keep changing your chief executive every 2 years. But in that time, all sorts of changes to the healthcare system, all sorts of governments coming and going. This is the first set of changes that actually make sense to me, to develop a collective responsibility around our more vulnerable patients.
Thank you. Also, having spoken to numerous Sport House surgery patients in my capacity as a PPG member, I believe that a walk-in facility for those who genuinely can't use a computer to submit an appointment request or for any other reason would be a great relief to many if they could just walk in, and I think it would allay their fears. Do you think there is a way of achieving this, even though it could be open to abuse?
It's a challenging one. I wouldn't say we look at people as abusing the system. When people have a need, they go where they can to get that need. And we're not interested in telling people what to do. You can't tell people what to do, Jackie. You can't say you're not allowed to go to A&E because if people think they need to go, they're going to go. And I think that those edicts apply to other people. The way to solve that is to make sure that your first point of contact is really good. And I don't think our first point of contact has been as good as we would like to see it. For instance, our website 2 years ago, if you typed in cancer, you got an offer of a pill check.
Oh.
So we've got a long way to go to make sure that our digital service is more user-friendly, more interactive, and people can get what they need. But if we're talking specifically around people who are digitally excluded, the telephone is our preferred voice of call. Walk-ins we kind of dissuade for a couple of reasons. One, because we don't always know who's here and what's on offer. And two, we're obviously very conscious of our footfall through the surgery as well, because of the history of the fire in Weybridge and this area being saturated with two practices that were more than twice the size combined of ours. So we don't really want to add to people's journey times. So in an ideal world, people would say that our digital offer is great, the telephones are great, and that they don't need to. But I think people do still find their ways to walk in, whether we formally go down that road or not, because of the challenges. I don't think we've got immediate plans, but you know what? This is an interactive session digitally. We'll listen to the feedback we get. We'll work with our PPG to make sure that our patients get the right offer.
Lovely. Dr. Bates, could you just explain the triage process and which doctors specialise in different aspects of medicine?
Yeah, so this is great because it's not just the doctors, of course. We've got our paramedic, our clinical pharmacist, and so on. For us, the most important thing was that everything came through one point, because then we could measure it. And if you can measure it, you can manage it. Now, I did a little exercise about 8 years ago. I was sitting in surgery. My phone was ringing, the door was going, my computer was pinging up various messages. So I thought, right, I'm going to write down how many sources of work do I have? And it was 18. If I counted all the email addresses, the blood forms, the letters, the bang on the door, the people would still write handwritten notes to us, even though you could email in, it was 18. And we realized, and there still is, and we're still trying to get to grips with this, a very significant amount of work, that we can't identify and we can't manage. And so the idea is that if we can push everything through one counter, we can measure it, and then we've got a chance to manage our workload. So once there's been a contact, either through the phone or through the website, they go through the same counter, and we call that AccuRx. There will be a doctor and an administrator looking at that AccuRx from 8 until 6:30, because some of them drip in later, every single day. And what we'll do is we'll look at the need. If we understand the need appropriately first time, we'll then send it directly off to someone who either has access or can specialise in that area. If we don't have enough information, we can then send questionnaires back to you through the internet, through your through an email, I meant to say, or through your mobile phone. We have sore throat questionnaires, we have back pain questionnaires. It just helps us cover off some of the red flags that we might worry about if we were in a normal face-to-face environment. And then again, it sort of helps us flow into who does what. Charlotte, fantastic with children. Diabetes, if I've got someone with an infection and diabetes, then we might go to Charlotte. John, obviously, big interest in mental health. Richard Redfern does the joint injections. Dr. Jones does a lot of our dermatology and all of our minor surgery. We've got Dr. Williams, who's fantastic.
Oh, yes.
You know, we've got we've got Zoe Henderson and Ruth Clark, who are our nurses who are running a women's health service now. And someone else has just popped in and out of my mind, clinical pharmacist, if it's a blood pressure. We've got so many other gynae doctors as well.
Yes, yeah. Just getting to the end of our questions, when does Dr. Redfern plan to officially retire, and will there be an opportunity for patients to express their appreciation?
So Dr. Redfern is now working 2 days a week, and I would call it a well-earned, it's not a retirement, it's not even a semi-retirement, but he's taking a well-earned break. He'll be around for the next couple of years.
Good.
And if anybody, well, in fact, if people would like to know when he is officially stepping down, we'll make sure we send that information out and keep an eye on our website.
Lovely. And the last question, many patients are extremely grateful for the generally high level of services offered by Courthouse Surgery. How might this be best expressed so that staff members realise that patients do appreciate their work?
It feels like we probably get around sort of 5 negative pieces of feedback to every positive. And we have a team of 35 people here. Very large admin team. There's so many people behind the scenes that will be looking after you without you knowing about it.
So tins of chocolate and... If
anyone would like to express, you know, all of those things, I've never seen anyone turn them down, put it that way. But the reality is that if something nice has happened and you can take 60 seconds to leave a positive piece of feedback on our website or email us, it's lovely to be able to feed them back to our staff, because I don't want to over exaggerate just how challenging it's been. So in that landscape, when something really lovely lands, it makes a really big impact. So if anyone would like to take the time to pay a compliment, we'd happily accept them.
Excellent. Thank you very much, Dr. Bates.
Thank you, Jackie, for facilitating this, and thank you so much to the PPG for all your hard work. You've joined us for all our flu clinics, gathered all the data for us, and obviously we're really keen to develop the PPG. We've got an in-person PPG, haven't we? We've also got a virtual service as well, and I think we're really keen to improve our reach and engagement with our patients, but also I think our diversity, and make sure that we're addressing all of our demographics for all of the community that we look after. So thank you so much.
Pleasure. Thank you.